Okay, we are about two past the hour, so we'll go ahead and get started. Again, hello and welcome. Good evening to everybody. Thank you for joining us tonight, and welcome to our April Study Club. If you're new here, welcome. And if you're a returning attendee, we are happy to have you back. This study club was founded in early 2024, and it really is a endodontic study club dedicated to building a strong endodontic community while providing meaningful peer-led CE education on a monthly basis. I just want to remind everybody who's on that we meet on the third Wednesday of each month. I know this is the fourth Wednesday of the month, but we did change it for the month of April due to AAE. But again, just a reminder, we meet the third Wednesday of each month. We'd hope, would love to have you all back and join us again for future study clubs. I'm going to very quickly review tonight's learning objectives. So for tonight's webinar, we are going to understand Gentlewave and the endo-restorative workflow. We're going to review strategies for platform building and review principles of endodontic access closure and immediate restoration. As you all may know, there's 1.5 CEs issued for tonight's study club. And I'm just going to very quickly go over how to obtain those CEs. Number one, you must be individually registered. Attendance will be recorded via Zoom, and there'll be an internal CE validation. Make sure your full name is visible. Oftentimes, if we're joining, it might say Zoom user or iPhone 17. And when we're doing the validation process, it's hard for us to know who was truly on the line. So if you're able to change your name, that's great. If you can't, just send us a message in the chat with your name so we will associate your Zoom profile with the individual who attended tonight. There will be a survey that is sent. You're just going to click the respond here, fill out that survey. Your feedback is very important to us. And then there will be a CE cert sent to you via email. And if you have any questions on this process, please feel free to reach out at education@sonendo.com, and we can help navigate any issues you may be having or any questions that you have regarding your CE. So I just want a reminder that this is an interactive session. Questions are highly encouraged, and there will be a dedicated Q&A session moderated by our Dr. Wendy Golden. Please enter any questions along with the presentation in the chat, and we will absolutely review these questions at the end of the presentation. There'll be time to come off mute and directly engage with Dr. Matthew Miller and Mark Limosani. So without any further ado, I'm going to pass it on over to Dr. Miller and Dr. Limosani, and I'm very excited for their presentation tonight.
All right, everyone. So really excited to be here. It's a topic that's been, ever since starting to speak with Gentlewave, Endo-Restorative has been a topic that I am so interested in sharing with everyone. Anything from tips and tricks to beginning to end, from integrating Gentlewave to ending with a final restoration. That's kind of been my jam since the get-go. Honored to be speaking here with Matt tonight and looking forward to answering a bunch of questions. First things first, always a disclaimer. I speak for Matt as well. All of this content is pretty much ours. At times, we'll use some slides that were given to us by Sonendo in order to facilitate, models or education. But pretty much all the cases are ours. So if you have any questions or you want a little bit more information about technique or whatever have you, feel free to ask. We'll also be giving our contact information on the chat. So we always make ourselves available to further this conversation. So tonight's objectives is really to understand how the use of Gentlewave as a device, and pretty much Gentlewave as the entire procedure, and how that all fits in from basically apex to occlusion. We're going to review plans related to platform building, from the easier to the more complex. And then we're going to basically bring ourselves from access closure to complex build-up restorations. So that's kind of the plan of action for tonight. So for those of you, there's a great range of people on this call. So I'm gonna give all the information for everyone as though they had not really been very exposed to Gentlewave. This is the new G4 unit. for those that had had G3 in the past and are now considering graduating to G4, I will say every single one of my team members are thrilled with G4. The ease of use, the ability to port it from room to room, there's just so many features that are amazing about this upgrade. But really, what we're here for and what we think to ourselves is in endodontics, our intention is to address the internal anatomy in all case types as effectively and efficiently as possible. So that would mean how can we clean and disinfect a tooth ideally in a one visit setting? The challenge that we have is in the past we had the capacity to do that, but it came at the expense of tooth structure. So it had become quite trendy to see these big, beautiful, white, bright shapes, and then 5 years later, a big dark halo along the side of a mesial root or mesial buccal root indicating that the root is since cracked. So it doesn't really serve to disinfect at the expense of tooth structure. So in endodontics, we really serve two masters, biology, but also structure. So a brief recap of how the Gentlewave works and more specifically how the clean flow handpiece works. As opposed to the way the mechanism action worked in the past, now everything is occurring in the actual head of the handpiece. The high pressure jet stream enters into access opening of the actual device itself, and that differential between the high pressure stream coming into the stagnant fluid ends up creating a cascade of cavitation. That cavitation cloud then moves from that handpiece down into the access and through the entire root canal system. The beauty of the Gentlewave procedure is these fluids are continuously being replenished throughout the entirety of the procedure, and the fluids are also being activated using multisonic energy. So the multisonic energy serves to activate every little different part of the tooth, from the access chamber to the main canals to the accessory canals into the dental tubules. In addition to that, we're also working with vortical flow, which is that continuous fluid exchange under negative pressure that moves the fluid throughout all the intricacies of the system. So there's no real other technology on the market that has the capacity to deliver this much disinfection agent to a tooth this efficiently.
So all that fluid dynamics with less collateral damage, which is ultimately the goal. I'm not sure how many of you happened to attend the AE last week and maybe had some introduction to the new files that Sonendo are now distributing. I haven't had a chance to try them because in Canada we're sort of a little bit behind on everything and we get things a little later. But most of the cases that we're treating in our practice are shaped way more conservatively than they were in the past. And the bulk of my cases, I'm using a Pro Glider instrument to create the bulk of my shape, and sometimes I'll blend it with a little bit of a 1504. Maybe I'll go up to a 2004. That's the adjustment I made in my own personal shaping. And the case results have been really impressive and quite rewarding. Just a couple examples. This is a lower incisor. We know there are two canals here. We can see the two canals there, right? I found two canals. I instrumented two canals. This is the final result. Pretty clean case. But on off angle, that fluid dynamics was able to pick up a third branch completely separate. There's no cone there. That's all bioceramic sealer. And this type of result with these slim shapes using high level irrigation has allowed us to achieve results like you see here. And there's just a bunch of cases that were completed recently by me in my practice, just to highlight the preservation of dentin, nice obturation, nice flow sealer, multiple portals of exit on most of these cases. So it's really satisfying. In addition, we've been able to tackle some cases that previously would have scared us, not believing in the science of endodontics and how predictable it is when you remove the source of infection. This patient presented lower second molar huge radiolucent finding. You can see on the CBCT, apical and vertical defect here. Tooth was moving plus two mobility. I did this case in one visit. Pre-Gentlewave Miller would have done this case in 2 visits or more. I would have waited to see, some type of favorable result. This is my final result. The mesial canals were instrumented to a 1504. The distal canal was wide open. I packed that with MTA in the apical third in one visit. This is the difference in soft tissue. 1 week later, I brought the patient back for a 1 week follow-up. You can see at the time of completion of treatment, when a patient has a swelling, this was actually a sinus tract that was enlarged. You can see 1 week later, it has resolved. And here's the recall at 6 months, full bone regeneration. And we got into the habit of taking 3D imaging to see our recalls to really highlight how much bone has regenerated. In this particular case, you can see the defect here on the 3D reconstruction and how nicely that bone is filled back in response to really copious irrigation and proper obturation. Another example, again, significant vertical defect, but again, just a necrotic pulp that's aggressively spitting out bacteria and creating a strong immune reaction. And when I first started using cone beam, unfortunately, my lack of understanding is you see these cases and you think that you can't grow back the bone, and we never saw endodontic infections this way three-dimensionally. We saw them in a 2D image. So when we started to see how vast they were and large they were, it made us hesitant to sometimes treat teeth like this, let alone in one visit. But it's another example. Again, slim shapes, just clean shape, run Gentlewave pack, and you can get really nice healing. You can see on the right here, and here's a 3D recall. You can see full bone regeneration compared to what it looked like before. So very nice result there. Here's another example. This patient presented, she had acute apical abscess, significant bone loss here visible. This is what the soft tissue looked like. You can see this is ready to explode. I did this case in one visit, a little bit more sealer than I would have liked to extrude, but just shows how much anatomy is there when it's clean, how easy it is to fill it. Even through small instrumentation, small shapes, the bioceramic sealer flows well. And again, brought this patient back 1 week later for a follow-up. And you can see how clean the soft tissue is just at 1 week in response. So again, a lot more cases just to highlight this one visit model with proper cleaning through a conservative shape using Gentlewave will allow us to go, from here to the obturation to get nice recalls and adequate bone regeneration. So you can see from top to bottom, all of these cases really demonstrate amazing healing. So the idea with the lecture tonight is to try to break down the process of how we get from a patient presenting with this problem. It could be an infection. It could, they may have an inflamed pulp. They need a root canal treatment. They present like this to completing the obturation with a permanent restoration and hopefully get nice healing outcome as we can see here. So not much to talk about with instrumentation. We highlighted that, just conservative instrumentation. We wanted to touch upon platform building. Platform building is obviously a major part of Gentlewave in the current model. There's been several talks about platform building techniques, and I think that's been in some instances a struggle for some users and sometimes a deterrent to use Gentlewave on specific case types. I've been practicing with Gentlewave for 4 years now. Exactly in a month from now will be 4 years of Gentlewave with my partners in our practice. So collectively, we've sort of developed techniques that work well for us. But there's so many ways to do platform builds creatively. So, we felt it would just be appropriate to share what works well for us. And so the platform technique can be like subdivided into multiple different types of situations. So I like to call it the classic platform, the onlay platform, and then the complex buildup. So the classic platform is basically the go-to. If anyone's just getting into Gentlewave or has never used it before and plans to try it, this is basically the go-to platform you're going to use. to do most of your cases. And so what I have here is just a video of a case from last week. So we can see here that we have an access cavity, and what we need to do is just kind of clean the tooth with some alcohol and then air dry to get it really dry. And the classic platform really just involves smearing a bunch of Sound Seal circumferentially around the tooth completely. It's a lot of material, but you want to have a really adequate seal. You want to minimize the chance of any type of opening to inhibit Gentlewave from working. And you want to polymerize that quite well. Every time I seat that matrix, I want to make sure it's actually fitting properly into that access chamber. And then I just flow the Sound Seal all around, just like this. And I seat it. That's it. Make sure it's sitting well. And I cure it multiple times. Okay, so I'll cure one side, the other side. This is sped up the video. Now, at this point, I'm ready to go, but I'll hit it again with the light. If I feel like there's a little bit of a cantilever effect where it's tilting on one side or another, I may add some Sound Seal. So just to get rid of some of those undercuts, give it a little bit more stability. This is like the 101 basic platform build. Okay, this will pretty much work every single time. If you do it this way, it's just a lot of material. Then I'll just make sure that I have, visibility into my access. So I just used, and there you saw a mud spur, large mud spur, and that's it. And I'm looking, just making sure I can see everything. And then we'll seat the PI. And very quickly you got your seal, and that's it. So that's the classic, okay? The premolar classic is a little bit different because the struggle with a premolar is the access cavity is smaller. So there's been many things and techniques that I've been exposed to over the years. But what I've learned on my own, and with trial and error, is that you just for a premolar, smaller access, you just have to extend the channel of the platform build chronally so that you can fit your matrix in appropriately. So I'm going to show you an example of a premolar. So same steps here. We're using alcohol just to kind of clean off the tooth and dry it to make sure it's really, really dry. In this case, I'm putting a little bit of bonding agent just to give a little bit of an extra adherence to the platform. And now kind of the same technique. I'm just going to smear it around. I like to do a full buildup on teeth that have interproximal restorations, just in case there's something I missed. There's a little bit of leakage or whatever. I don't want to risk not having a perfect seal. Here I'm taking a perio probe and I'm just kind of flowing it around to create a nice perfect chamber, and I'm curing. Okay, then I'm going to add more and I'm building it up vertically. I'm extending my access coronally here by just building a second layer and like adding a donut on top of another donut. And I'm going to take my probe. I'm going to make that nice and neat. I like using a perio probe here. You can use an endo plugger. You can use an endo explorer. It doesn't matter. Now, before I put the Sound Seal material on, I'm going to make sure that matrix sits nicely all the way into that channel, and it just becomes exactly like the molar. And that's it. You can polymerize multiple times. Okay, I'll just fast forward that, same little modification, and then we can start running Gentlewave, and you'll have a good seal. Okay, you can see the line there. Okay. Okay, so then there's the anterior tooth. So just like the premolar, the anterior tooth has a small access. So I have an example here of an anterior tooth. You can see the access cavity, the same principle. In this case, what we want to do is just extend that access cavity coronally and make it larger with Sound Seal. So I'm putting a little bit of bond on the anterior tooth. It'll help adhere that platform build better. And I'm just kind of extending the cingulum out with Sound Seal. I'm making a donut all around this tooth. I'll take the perio probe, I'll sculpt it, I'll make that channel nice and round, smooth, and then I'll polymerize. Now, you may notice on the buckle, I didn't go all the way down to the CEJ. You don't have to if there's no restoration there. It's much more important to do it on the back of the tooth, on the lingual aspect. And I'm just kind of building up this little donut, creating that shape, extending the access, polymerization, testing to see if it seats. It does. So now the material is on, I seed it,
Mm.
and then I polymerize. You really want to make sure you also polymerize well in the lingual aspect here so that it's not soft. I can do some indirect curing. You can angle your mirror towards the lingual and cure in your mirror. I don't know if it works. It seems to work for me. Nothing scientific about that. It's just a Millerism, but it works well, and that's it. And then you run your Gentlewave. So those are the three main teeth that we treat. In cases where you have a good seal or you want to save some sound seal and not use as much as I just showed you, you can do what I call the onlay buildup. So again, same thing, alcohol, clean the tooth. In this, I always put a little bit of bond, little tack, little spots of bond just to adhere the sound seal again, polymerize. And now I'm just doing the donut right on the occlusal surface. I'm not going anywhere really further or closer to the gingival margin here. So I'm just doing a little donut, just like that, polymerize, seat the matrix, polymerize in multiple areas. Fast forward the polymerization. Okay. Just make sure I have good access there and then run Gentlewave. Okay, and it works very well. I do this usually on teeth that have crowns or really, really, certain intact restorations that are not leaking, of course. So it works really well in those cases. And then finally, the complex buildup. This is the one that deters people from using Gentlewave. With proper planning, you can get away with it. It's not so difficult. So I'll show you a case where it's really broken down. This is after, obviously caries removal, shaping. We're ready to run Gentlewave. So you can see how beat up this tooth is. Here I'm using a hemostatic agent to control any bleeding from the gingival tissues. So this is a product called Catrol. And, I'm just checking to make sure everything is clean. There's no bleeding. This is alcohol, same like we used before. I'm drying the tooth. In these cases, I'm always going to put a little bit of bond to help adhere the sound seal. Polymerize. And then I'm going to place this directly over the tissue and I'm going to hug the embrasures of the adjacent teeth to get a little bit of retention here. You can see I'm putting quite a bit here. And then I'm going to go to my perio probe and I'm going to sculpt it in and make sure it's sealed. I'm going to up the mag a little bit and I'm going to look down and I'm going to make sure that I'm not leaving any gaps. So that looks good to me. So polymerization, I'm going to add more. And as I'm adding more, it's just becoming pretty much like a classic buildup now, right? And again, I'll just round that off. So you see, we're just rounding that off. And then we're ready to seat the matrix. Polymerize. See, I did some indirect polymerization there. Take off the matrix, clean it up, and then we're ready to go. And you can see we get a seal right away. See the line there. So that's my take on platform building. And there's so many ways to do this creatively. So I mean, all the people that I've seen, teach me about platforms like Kirk Curry and others who have spoken about platforms. I thank them because I've learned so much from them. This is just my take, and there's so many other ways that you can do this too. But I just want you to know that it's doable in every case type. So we talked a little bit about platform building now. Now we're going to move to obturation. And I saw a really cool talk on obturating minimally prepared canals given by Scott Hetz. So I always give him credit. Does a really great job with that lecture. But so many Gentlewave users like Scott, and here's a picture of James Smith, who I've watched several times speak about obturation. Just learning from these Gentlewave users has really been truly rewarding for me, for Mark, in our journey. So I want to give them credit, and also to the others who have helped us along the way. We know that we don't need to shape the canals large when we're doing a Gentlewave procedure, because Gentlewave, moves the fluid through those small shapes. If you go smaller, the difficulty is obturating those canal shapes predictably, without voids, without struggle. So that was a bit of a learning curve as well. But the bulk of our cases that we're shaping are finished at around a 1504 or 20 at most. And what we're doing is a single cone, synchronized hydraulic condensation technique with bioceramic seal or high flow. Most of my obturations, I'm using this 1504 cone from Dentsply, this Vortex Blue Conform Fit Gutta Percha. It heats really well, sears nicely, it's clean. So we like using that. In other cases, we'll use old school, fine or fine gutta percha. I use this product from Diadent. And the technique that's been working really well for me is the technique that was described by Scott Hetz in his lecture. So basically what you'll do is you'll finish your shaping and you'll fit your cones. This is just me fitting my master cone. And now I'm ready to obturate the case. So I'm going to inject bioceramic sealer. So here's the injection of bioceramic sealer. And then the idea is we want to move that sealer through the canal to the terminus as best we can. And what we do is we use either our master cone, or we can use what has been termed the sacrificial cone, whose sole purpose is to deliver that sealer into the canal, almost painting it along the walls. And then that's it. That's its purpose. And then it gets tossed in the garbage. And this is what it looks like. You take it out, you should see sealer uniform along the entire surface of that gutta percha point. So you take it out, and then you put a little bit more sealer. So here we are re-injecting a little bit more sealer, and then you place your master cone, you pack it, and then you immediately seat your backfill device and backfill. Okay, and that's the technique. And it works really well to move that gutta percha and that sealer into all the nooks and crannies and branches of the root canal system. So I'll show you a video of that, of an obturation that I did. So this is just, post endodontic instrumentation, Gentlewave, et cetera. We're ready to obturate. So I'm placing the sealer. You can see there was some confluence there. Seating the canal, we're out. Put a little more sealer. Place the cone back, done. Now we're going to put MB2 in. We're out. Put a little more sealer. Cone goes back in. There you go. Now we're going to sear these. Okay, and then we're going to use the warm gutta percha. We're going to seat the obturator needle here, and I'm going to use that as a plugger, and I'm going to use the warm gutta percha as a compactor. We're going to put a ton of pressure on this now, and it's going to move that whole massive sealer everywhere. Okay, it's not super clean. It's going to look a little messy. We're going to clean that up later. Here's the distal canal, seat out, more sealer, final seat, and then we're going to heat, we're out, and we're going to seat the obturator needle, hold it, push, and then extrude our gutta percha. We're going to pack, and then we'll get to the last canal. This canal was naturally bigger. This is 3004. This is just a 30 cone. I'm doing the same technique. But what I've noticed with bigger cones, I can do a true down pack. I'll just pack it to wherever the heat source goes. And in these cases, to avoid, any type of void, I'll just kind of sit that down with a plugger, and then I'll backfill it, conventional. Okay. And that's it. And then we're going to clean that all up. We'll fast forward this video. We'll clean it all up. Just make it neat. See there's sealer there. I like to use an ultrasonic just to get rid of some of the sealer, and we'll do other techniques to clean the access cavity afterwards, okay? So this is kind of what it looks like after. You can see the hydraulics and the sealer, how it, it fills some of those accessory canals and anatomy, etc. Okay? Another example, a lower molar, you can see the slim shapes, but nice hydraulic anatomy. Here's another example here. I think I can magnify that. There you go. So you can see, the two canals that had cones in them, but look at all that accessory anatomy that gets filled, through this type of obturation technique. Another example, you can see the accessory anatomy here, especially here. Look at that, three portals of exit. And here's another example of this, anatomy and some of these surprises. I call them bonus anatomy that we get sometimes when we finish a Gentlewave case. And then finally, just another one that looks, you can see there's something happening here. And we had an extra surprise here in the apical third, all through this type of obturation technique.
So this was, we talked about the single comb possibility. One other option or trick I have up my sleeve is more of a squirt-based obturation. The challenge with Gentlewave is it cleans so well that you will very oftentimes get confluency, meaning both canals, or there's two canals that merge and then resplit. And the challenge is, how do you generate hydraulic pressure in the system? So I've developed, or I haven't really developed it. I kind of just thought it through of how to use pluggers to create an opportunity for more hydraulic force to be created. So basically, everything that Matt has described with related to placing the sealer, then using the cone to then place the sealer all the way down into the system and ensure that it gets it to the apex. But then instead of placing another cone, in this case, what I'm doing is I'm using a paper point in the shorter or the merging canal and using the paper point to then push the sealer all the way into that intricacy and any other bifidities that would be occurring at the tip of the root. In addition to that, one thing that you have to think about is sealer is not going to move into areas that are occupied by fluid. So one element to getting good sealer hydraulics into the system is to have a very dry canal. And one way of doing that is you place the paper point and then use a very, very low jet stream into the tooth to be able to move the moisture into that paper point. So this is an example of basically I kept one canal with the paper point in place, and I'm injecting sealer in the other canal that is confluent. MB1 is confluent with MB2, and the idea is the wicking effect of the paper point is going to pull sealer into that space. So I'm using a Navi tip in this case as opposed to the no waste tip. I inject. So now the sealer is getting pulled into the confluent canal, and then I'm going to remove that paper point and then inject with the obtura in that second canal. You got 2 to 1, then a redivision, and then a resplit in the apical third. So in these cases, oftentimes we're really only instrumenting one pathway to length, and we're relying on obturation to fill the system. Another strategy that I use for canals that merge is basically step one, I fit one cone in the canal that gives me a straight pathway from the portal of negotiation or the most occlusal aspect of the canal down to the main portal of exit. So there's always one canal that's more of a straight shot and the other canal that merges or resplits. So I always get a good cone fit in that one. Then I keep the paper points in the canals until ready. I remove the paper point from one canal, and then with the pre-fit gutta percha, I'll inject the BC and then place that cone to length. And then instead of fitting another canal into that merging space, I'll basically backfill. So it's basically a squirt technique. If there's a mid-mesial, so if there's, let's say, 3 canals in the mesial system, what I'll tend to do is fit one cone, then place the plugger in, let's say, the mid-mesial, the mesiolingual, then backfill the mid-mesial, remove the plugger, and then backfill that last pathway. So in this case, these are the types of ways of getting that in anatomy filled in between the two roots of the teeth. So I'm fitting one main cone to the tip of the root, and then I'm using the backfill to build all the hydraulics and really push the sealer into that isthmus tissue or isthmus area. So in this case, basically I'm showing how I fill one, like let's say the MB1 canal is filled with sealer, then I'll use my plugger to then push the sealer into that orifice to move it down into the canal system, and I'll use the obtura to then squirt obturate and backfill the system. So that's an image of just having placed the plugger into the orifice, and then once the plugger is placed, I can then place my obtura tip into the joining canal. So the plugger basically is there to maintain that pressure. If I don't have the plugger there and I just squirt, it's just going to back up and kind of short circuit as opposed to going all the way down to the apex. It's going to come up the side of the joining canal, and I'm not going to get a dense fill. So that's just an example, with an MB2. Again, similar concept. This would be with a lower molar. Plugger is placed in the mesiolingual canal. So plugger is placed in the mesiolingual canal. Obtura is then placed in the mid-mesial and then backfilled. So it's the best way to, without trying to fit cones at specific lengths, to be able to deliver sealer and gutta-percha into the system under hydraulics and really fill all that additional anatomy in the apical third of the tooth. And this is an example of a straight squirt technique. There's some cases where patency is extreme. We have a whole discussion related to cases where we don't have apical patency and we're using the device to allow for that to be possible. So in those cases, I'll just basically inject the canal with the BC, use the plugger so that I don't have a pool of sealer in that space, then use my obtura with the smallest gauge to then backfill the case. So one thing that you need to accept when you are choosing to fill smaller shapes is there's cases that it's not going to come out the way you want it to, and you have to be comfortable with the idea of going back in, tinkering, and thinking of circumstances where you may want to take a cone fit or you may want to repack a case. I'll show you an example. So in this case, this is exactly it. First of all, my cone had not gone to length, sealer had not gone to length. I hadn't put enough sealer in this case. So in this specific instance, what I did is I was able to pull the cone out, inject more sealer. I performed the exact same technique as Matt, but what I did is I used the McSpadden compactor in the mesiolingual canal to then really hydraulically move the sealer and the gutta percha into the apical third. So you could see once that occurred, this is the reason why my cone got caught up. There's actually an apical split in the apical third of the mesial system.
This is just a standard case where I got a little bit unlucky on the obturation. So here's my final result. Doesn't look too bad, but when you look at it up close here, I didn't like this part here where my cone stopped there and I can see a little sealer tract. And, most Gentlewavers will just leave that and let the sealer do the job, but it was bothering me. So it's just a quick repack. You can go in and pull the cone out and, just confirm, seed a new cone and, be happy with the results. So that's what I did. It takes 10 minutes. So you just go back in and do it. Here's another example of a case. You can see this lower second molar here. You can see how it's sort of like a C-shaped anatomy and the canals come together and re-split. Again, I wasn't happy with my final result here. You can see that I got sealer and then all of this is sort of empty. It's like the sealer that was supposed to be here ended up here. So that wasn't fun. And this was bothering me. So again, I just took the 10-15 minutes, ran a little bit late, and I was able to get a decent result there where I can repack and have a satisfying fill. And then last week, I had this tooth to treat, this premolar. And that didn't look like fun, but I didn't think it was going to be as hard as it turned out to be. Here's a scan. And what you can see here, I'll just zoom in. over here, it's like a C-shaped type of anatomy, and you can see that there's definitely two canals and like a little bridge between. So my plan was, you know what, I'm going to clean the two outer canals, shape them, fit those cones, put a bunch of sealer, pack it, and let Gentlewave take care of the rest. And so I did that and fit my cones, packed it, and this is what happened. I took a check film. I said, "Oh my God, I'm not even in the two outer canals. The two cones are in the center here, and all this is sealer." I said, "This looks like crap." All I did in this case was wipe the sweat off my forehead and go back, to my heat source and really pack down as far as I could and just sit and lean and push as best as I could. And then I took another check film, and I kid you not, I didn't add any gutta percha here. This is all filled now, a little bit better. I wasn't happy with this void over here, and so I finished it like this, restored it, and I got this four canal lower second premolar with some extra portals of exit that I've never had before. So that was a decent result given the complexity of the case. Okay, so we reviewed these three components. Let's talk a little bit about closing an access cavity. I'm not sure how many of you are doing some final access closures or buildups, and we both Mark and I, this is a big part of our practice. At the end of an endodontic procedure, we really try in all instances to close the access cavity and to seal the work prior to the patient getting a crown. Some cases they're not getting a crown right away, so it's been a passion of ours. So I'm just going to kind of highlight what happens after the root canal treatment is done. Sodium hypochlorite is an amazing chemical that dissolves pulp tissue and removes bacteria, but it also really beats up dentin quite a bit, especially with the amount that we're using for root canal treatment. It denatures the proteins and messes up the collagen. It oxidizes the dentin. All of these factors decrease the bonding effectiveness to dentin. So we need to find a way to freshen up the dentin following root canal treatment and improve the bond. So this is what I've learned over the years. So when the root canal treatment is immediately completed, as I mentioned before, I use ultrasonic and water just to kind of clean it up. And then I take, a very, very large round slow speed burr and I shave, and I'm not gouging and I'm not digging into the dentin. I'm just shaving a superficial layer of dentin away with the round burr. You can do this probably with an air abrasion tool or equipment. I choose to use just a round burr. I'm not enlarging anything. I'm just freshening up the dentin. And then I etch, and you want to leave your etch for the appropriate period of time. And then you want to rinse. Now, what I did there, I'm just going to pause the video. I rinse, you saw it was a very quick rinse. I rinsed for 1 minute. I rinsed that dentin for 1 minute. And the reason for that is you really want to remove all that etched debris and hydrate the dentin. And then you don't want to air dry that dentin. Basically, I'll take a micro suction and dry out the access cavity with a micro suction tip, and that's how I dry the access cavity. So then we proceed with bonding, and I use quite a bit of bonding agent, polymerize as usual, and I'm using a dual cure composite here. This is Luxacor, and the setting time really is around 5 minutes for proper set. You don't want to polymerize this with a light right away because you're essentially debonding your restoration right away if you hit it with the light immediately. So this is a good time to step away, grab a sip of coffee, go answer a few emails, just walk away from the patient for a few minutes, 5 minutes. So I waited 5 minutes there, and then we polymerize. And this is a 16-year-old kid. So here I am just, capping this dual cure composite now with a regular composite. So I'm actually trying to do some anatomy. I was never good at this stuff, but this is just injecting little balls of composite and just kind of sculpting it to recreate something that looks decent for this patient. He's 16. He's not going to be getting a crown right away. Um, if maybe ever, just a big occlusal decay here. So you just place the composite layer by layer. I'm using an Explorer here to make some grooves. Polymerization. And then, if you do this right, oftentimes you don't have to do much occlusal adjustment. if you build up these cusps and grooves and anatomical components properly, you oftentimes don't have to adjust them. So here I'm just smoothing it off. I'm using a white football. I'm not going into my anatomy. I'm just kind of smoothing everything off. And this is just a rubber wheel and rinsing, and you get an idea. It's not perfect, but it looks decent. It'll suit this patient for a while. And this is the final radiograph. You can see how big the decay was over here, and that's the final fill. Another example, this is more related to an adult who's going to be getting a crown, where the anatomy of that final composite isn't as important. Again, I'm cleaning with an ultrasonic with water, gets rid of the sealer really effectively, and then the same principles. Okay, dentin shaving, just minimal shaving, just to clean up and freshen up that dent and expose the collagen a little bit more. Rinse, and then the same thing. Etch, leave your etch for the appropriate period of time. Rinse for a minute, get that dentin hydrated. And then we carry on with the bond. I'm going to fast forward this. Okay, and the Luxacor is being placed. You can see it's being placed here. I'm just moving through the video. 5 minutes, we wait, then we polymerize. Okay, and then I put a composite cap on. Move it into the anatomy, polymerize, and that's it. And then that's this case over here. So you can see the anatomy and the core is pretty clean. And this patient's ready to return to their dentist for a coronal restoration of a crown.
So I'm going to take over and talk a little bit about Gentlewave and complicated buildups, broken down teeth. One thing that I would definitely consider is clamp selection and there we go. Clamp selection and certain preliminary steps that you should think of before even starting the case. Um, One is split dam technique is extremely effective. If you're not going to be performing split dam technique, you better have some Teflon ready to be able to seal your apical margin. But in all the cases that I'm going to be showing, we're performing some version of a localized crown lengthening or a Dovgan-Cotomy borectomy. We're just removing all that inflamed tissue interproximally. Secondly, you really want to have a very, very dry field. If you're trying to place sound seal on a tooth that's wet, on a margin that's wet, you're not going to get adherence, and you're going to have to rebuild your platform. Oftentimes, in many of the in-person lectures that we give, I'm a big proponent of using glycopyrrolate, which is a drug that's typically given IV, but it can also be given in the mouth. And it really, really, really helps to dry secretions. It's just a very, very useful tool, especially when you're dealing with kids that tend to salivate a lot. So for the Dovgan Cotomy, who's possibly on this call, borectomy, I'm a big fan of these crown lengthening burrs that are sold by Brasseler. They're called a 956 FG end cutting burr. So they don't have any side cutting properties, so you can move along the root of the tooth or the margin without cutting into it. Cutrol, as Matt had mentioned before, is extremely helpful. Ferric sulfate, just at a higher concentration. The only thing that you have to be mindful of is you really have to make sure to remove it from your preparation because it will affect the bond. So this is just an example of how with split dam and using the 956 end cutting burr, you could have very, very effective gingivectomy without even needing a laser or a touch and heat or a System B or whatever have you. What I've come to realize is when the one thing that I would recommend if you're dealing with extremely hyperemic tissue interproximally is to blanch that tissue using 1 in 50 epinephrine anesthetic-based solution before you perform that gingivectomy. What I'm doing here is Now that I've removed the tissue down to bone, I'm applying Cavit, which is not moisture sensitive, it's actually hydrophilic, in order to block off the interproximal area in between the tooth that I'm treating and the tooth in front of it. So that will allow for us to be able to get a really, really dry margin. And with a really, really dry margin, we're going to have better adherence of the sound seal. So now that I've created that isolation, I'm not getting any seepage of blood or saliva coming onto the preparation. Now I go ahead and place the I place the alcohol. Now I'm placing the sound seal. So very similar to Matt's case. The only difference is I used Cavit as an extra barrier to prevent any moisture for seeping in. And I'm just painting the sound seal onto the preparation and making sure that I'm not going to get any bleed. In this case, I don't really like using bonding agent because I find that that film is becomes more even more challenging. The film of sound seal becomes even more challenging to remove from the preparation afterwards. So, everyone that's why we're two of us giving this lecture. Each one of us has our different techniques. Whatever works for you is great. But like I said, I definitely recommend a split dam isolation when we're dealing with these more broken down teeth. Perfect. And exactly as Matt had shown, this is one of these circumstances where I get to place the sound seal. What I do differently than Matt is I like to create a union between the sound seal that was placed from the platform and the sound seal that I had placed before. That just gives me more stability. But again, it teach their own. And in this case, we cure again, we reaccess, and we're good to go. So this is an example. So we had interproximal decay. We performed the split dam. I was able to remove that band of tissue. So now it's somewhat hyperemic. I use the Cavit to block off that whole area and allow for me to have a nice clean margin to work with. Then I incrementally built up the wall, and then the entirety of the sound seal around the tooth to then be able to run the Gentlewave. Now, this is particular because in the past I was doing quite a bit of this. I'm using the sound seal as a custom resin matrix. So for those of you who are part of TDO, there was a TDOer that had come up with the concept of using green opal dam, as a custom resin matrix into which the buildup materials can be placed and then come back. And that person's name is Michael Trudeau. So I pay him homage every time I show these ideas because in this case, seeing as though we're already using the sound seal in order to create that closed loop system, all I was doing, or all I've been doing, is cutting back in order to create a casing for our materials to set, and then for us to be able to place the margin. So this is a perfect example. We have a C-shaped anatomy. This is after having run Gentlewave, after having done the obturation through the platform. I cut back in order to create that casing, and then that casing will then be able to absorb or encompass all of the materials, dual cure composite resin that's then placed inside. Afterwards, the beautiful thing is you can then pop off the sound seal and then refine the margin. So in this case, I'm placing the margin onto tooth structure, gives a clear, placing the finish line onto the tooth structure gives a very clear indication to the restorative dentist as to where they can start their margin. Since it's done on the microscope, it becomes a lot easier for them to work. And for the practitioner placing the margin, you could see a very clear distinction between tooth structure, cavit, and stark white buildup material. So that's the final right there. One thing that I would highly recommend is getting a very strong curing light. As a matter of fact, I have a Velo and I've had it forever. I've come to realize that the woodpecker more premium curing lights work just as effectively. May not have the same lifetime with a woodpecker, but definitely does the trick. In terms of additional moisture control, using something like uh, um, not opal dam in order to seal around the rubber dam clamp any material like Cavit that's more so hydrophilic. uh,
Oraceal, Mark, or caulking.
exactly, what did you say?
Oraceal?
Oraseal, that's it.
Yeah.
Thank you, thanks, Matt, I appreciate it. Using Oraseal is super helpful, especially in those areas where you're getting a little bit of seepage. So this is an example of what I see prior to placing the final restorative. I see the very clear distinction between tooth structure, obviously gutta percha, sound seal, which is blue, and cavit, which is white. So I'm basically cutting back to the margin and then filling up that entire area. And then when I lift off the sound seal, I'm left with that little strip of tooth structure that I could refine. So it just has a very clean workflow from sound seal, cut back, restorative, and keep moving. That's the margin there. That's the final x-ray there. One thing that you want to make sure of is if you're going to be performing some version of borectomy, you want to give your patients some home care instructions. Uh, Chlorhexidine and a Proxa brush to be able to clean the area is a must. Otherwise, they're going to end up with very gnarly tissue. So this would be an example of having removed the tissue, having placed a cavit, and this is what it looks like after having removed the cavit, and this is what it looked like 1 week later. Very nice, very clean, no significant bleeding on probing, ready for the final restoration. So one thing that I've started to integrate into my endo-restorative journey is really creating a proper seal. I had noticed that many dentists were ending up with margins that are not so ideal, and some of them were actually pushing to have their margin placed on restorative material. Now, in the past, placing restorative material on, let's say, amalgam, a well-finished, well-polished amalgam, worked out really well. The challenge is in some communities, amalgam's a no-no. So now we're back to figuring out what would be an appropriate margin to place. And what I turned to was biomimetic dentistry. So one, I guess you could say, supply that is a game changer and that is super cheap is copper. So if you want to write this down on this website, Basic Copper, you'd be able to order it by a bunch of spools and you could cut it to your liking. So this is the exact size that I like to work with. I placed one order. I think it was like 30 bucks. I still have a ton, but it is just so practical, whether you're using it alone or whether you're using it to seal off a margin within a matrix. It is just super helpful. Yeah, it was 40 bucks. So this is an example where my intention was not necessarily to do a full gingivectomy. My goal was, well, would I be able to create a good seal of that margin without having to go through what I had shown before? So the idea is let me rebuild the wall, then perform the endo. And sometimes that workflow actually ends up working better. So here you could see I did end up placing some cavity at the base, but I'm using the copper as a good way of wedging and sealing that margin so I could perform an immediate dent and seal in that deep box. So that's what that would look like, and I recaptured the contact there. This is another example. Some cases, it actually becomes more challenging to try and perform that gingivectomy and rebuild the sound seal in that area, then remove it, rather than creating a good contact from the beginning and then doing your Gentlewave procedure as you would a normal class 1 restoration. So this is exactly, in this case, I used an anterior clamp or basically a butterfly clamp, which kind of kicked the prongs out of the way. I was able to use a wedge and the copper to create that deep margin. And then after I have the deep margin, I'm able to then fit any other different matrix to create the contact that I want. So it's a step of deep margin elevation that allows for us to seal that wall that's been affected, and also create that seal to allow for us to be able to run the Gentlewave. Yeah, here's another example, pretty significantly broken down upper second molar. So in this case, I was able to fit an actual matrix on the side of the tooth. So creating my immediate dent and seal, creating my barrier. So barrier's done. Now I can proceed as if I was dealing with a class one restoration. The thing that I like about this strategy is it allows for the patient to leave with a good contact. So for many of my patients, they're off to get a crown within a week or so. So I'm not too concerned about that. But there are some that are not. And in those cases, I really like to give them a good contact and a good margin. And then eventually, when they're ready to have their crown placed, worst comes to worst, if the dentist ends up placing their margin on restorative material, I know that I have got a very, very good seal in that the deepest aspect of the box. So in this case, this patient was actually a dentist, and his request was, I didn't have this crown. This crown was placed not that long ago. Would it be possible to try and keep the crown? I didn't give him any promises, but at least I said I'd do my best. So this case, interestingly enough, ended up having three main portals of entry into the mesial canal system. And what I did was I was able to, so there was a little bit of a furcation involvement on the distal aspect of the furca. I was able to pack Teflon tape and really create a seal along with a wedge and and a matrix a little bit, just slipping a matrix beyond the contact to create some version of a seal from that crown. So you could see there we were able to get a margin, and at least his crown is safe for now. In these cases, no, we're not talking about tooth number three, talking about tooth number two. This is kind of a combination of different techniques. One, all the caries were on the buccal. So as opposed to making the access directly occlusal, I decided to slant it from the buccal and then restore the buccal afterwards. Two, seeing as though the margin was in such close proximity to the crest of bone, opted to go with gingivectomy, borectomy, and subsequently what I ended up doing is using the Sound Seals matrix to then place amalgam. Because of this guy's super high caries risk, it just seemed the most appropriate material to use. So this is the view looking inside the platform after having completed root canal therapy, completed the obturation, and hollowed out the matrix in order to accommodate the restorative materials. So this is what it looked like. I basically fluted, festooned the furcation to follow the root of the tooth and ensure that there wasn't going to be an overhang. And as you can see, most of the carious lesion was all on the buccal, and the palatal aspect of the tooth was left untouched. I mean, in these cases, the endo is kind of the easy part. The restorative is by far much more complicated.
All right, great. So that brings us to the end. We greatly appreciate everyone's attention as we were given the opportunity to discuss something that we're very passionate about. This is a day-to-day type of thing for us. And if there's anything that maybe you took home from this, then we feel like we've accomplished our goal.
Okay.
Awesome, you guys. That was just incredible. I feel like we could almost all watch it again. We have not had a restorative lecture so in depth like that. So, before we get to the questions, do either of you were you general dentist before endodontists?
I did a year of general practice residency, but Matt, you could speak to your experience.
Yeah, I did. I graduated dental school 24 in Montreal. There was like a pre-dent program, so you skip a bachelor's degree and go right into dental school. So I did a year of residency at the Jewish General Hospital, a McGill University affiliated residency, and then I figured, I'm young and I'd like to invest more time because I wanted to be a super GP at the time, and so I did a second year residency. And in that second year, I sort of got an itch for endo, and that's when I applied. So I ended up doing 2 full years of residency, and I worked a year in private practice before I started endo school. So I had some experience in restorative, but I've done a lot of courses afterwards. I did a restorative course at the AE last year. Um, so, and I've just always I've always taken, had a, desire to, when possible, to close the access cavities permanently, immediately to avoid that transitional phase and that risk of leakage, et cetera, into the access cavity. So it's just been a
Great.
passion. Yeah.
Sure. I have some questions on that, but I'm going to get to the audience first here to make sure they're answered. So maybe you can both answer each question. Matt, you can come first since you're first on the screen. So if you're instrumenting 1 millimeter short, does your gutta percha not go to length or does it?
Okay. So that's a great question. So I don't instrument a millimeter short. I instrument to full working length, apex locator working length whenever possible. Um, the instrumentation short, I think, was an older Gentlewave philosophy when we were worried a little bit about the safety protocol, safety, profile, and wanting to stay away. But with clean flow, there's really no issue instrumenting to full length. So that I've always fit a cone to full length. That's just
Okay.
my technique. Yeah, except in cases where patency is not achievable, I'll rely on the hydraulics and sealer to flow in. But in most of my cases, I'm trying to get a cone to length.
And Mark, are you instrumenting to length or staying back?
I instrument the full length. I would agree with Matt. When version 1.0, the three-piece handpiece, meaning there was you had the actual handpiece, and then you had these sizers that you had to place. The safety profile of that device was not the same as CleanFlow, and I think instrumenting short, not instrumenting. There were certain things that you had to do to make your life much easier and not to run into trouble. CleanFlow is taking all that away. So I instrument everything pretty much to length. The only file that I'll not necessarily take all the way to length is a 2006 V taper or DC taper. That instrument will be taken pretty much to wherever it goes, or by and large, more or less 1 millimeter to length. That's kind of the way I do it.
We've got a sealer puff question. Do you like to try and eliminate those? Are you comfortable with sealer puffs? How do both of you feel about those?
Yeah, look, I used to when 10 years ago, I would cringe with the amount of sealer I'm pushing out of the tooth. It's just a different, it's a different look. We need the seal. We need a high flowable sealer to move into all those branches that are now clean. And so, what I don't like seeing is like a poorly controlled sealer puff, where like I inject too much or and I lose control of that look. But I don't mind seeing the little puffs because I know that the sealer is going to full working length and slightly beyond in those cases, and especially with the lateral and accessory canals. So I'm okay with it. I do get upset though at myself when I push a bit too much sealer into the canal and out the canal. That's just a bit of a learning curve. It'll still happen even when you get comfortable with using high flow sealer, but you know, it's okay. The patients tolerate it well. It's very biocompatible, and I haven't had really any issues post-treatment wise.
It's kind of like pick your poison. And in both circumstances, you're dealing with something that's somewhat unideal. I think with time, we end up developing technique that allows for more control. I think the technique of placing the sealer and using the cone to deliver it to length is the second application of sealer. We're not really putting it as deep in the canal, and we're never really binding the tip. So the first application of sealer is designed to be delivered to the apex. The second application of sealer is just to kind of fill in the gaps. So I think when following that sequence, you end up with less, significant puffing.
So going back to the case where you decided to pull the gutta percha and redo the canal because you were a little short there, they were asking, are the if the system's clean, is the white line really that important?
In my case, no. I was actually reviewing the case, the presentation with my partner today, and he told me I was crazy for pulling that that cone out. But it's just, you know what? It's like when you're searching for an MB2
Yeah,
and you can't find it on the line and you start digging a little bit, and when like maybe Gentlewave will pick it up, but like you can't resist that like urge to go for it. That's the same urge. It's just for me more of it was more of an aesthetic thing. I knew it
yeah.
was an easy fix. I don't always go back in, but on those cases that I showed, I made the decision to go back in. It would have the outcome would have probably been the same.
I noticed the rubber dam was off, and those are the hardest one because the assistants usually has the tray already back and gotta have
Yeah,
them back.
it's rare that I'm going to take a check film even before placing the restoration. And so, yeah, I get burned like hard. I have to go access back through my composite. It's a hard 10-15 minute delay, but I make the decision depending on the case and how I'm feeling. And that's it. Just, I'm trying, my mission is to try to be as the best I can be for the patient. Um, on that premolar that I showed, that I took a check film because I was going to put a fiber post, and it was a crazy case, but like what I saw there, I never expected to see. That was
Yeah,
just wild.
that had to be a fun drive home because that was pretty amazing.
Yeah, it felt it was a cool result, but I had I don't know, it was weird. I had depression after for some reason. I felt like I didn't get the best of it, but anyways, it was a interesting case.
The lower premolar, that was crazy.
Yeah, I didn't find two canals. I mean, I felt like a loser a little bit.
Wow.
Yeah,
Wow.
yeah.
All right. So, with each of you, what burr do you like to use to cut back the sound seal when placing a buildup?
I use uh, a chamfered green grit diamond burr. That works. I mean, it's the same burr that I use to access a tooth, so it's already on the handpiece. Um, it works really well. And
Great.
and yeah, even in the apical aspect of it, you could just the beautiful thing about there's that clear distinction between sound seal, cavit, and tooth structure. And so you have a very clear visual as to where to stop. So
Sure.
it works really
Yeah,
well for me.
same. Sometimes I'll use a red diamond, like a finer diamond,
Hmm.
football diamond, excuse me, just in combination with the chamfer, just to give me a little bit more opening, rounded opening. But yeah, same.
So before I get to some of mine, I'd love it if anyone wanted to come off mute or camera and ask these two any questions.
Yeah, actually, John made a great comment in the chat, mentioning the fact that the smaller the shape, the closer the cone needs to fit to the apex, if not slightly beyond the apex. That is so spot on. Like I would agree. If I have a 2004 cone, like a a canal that has more body to it, I'm okay with that cone fitting, let's say, point 0.5 to length. But if I've got a fine cone or even a 1504 cone, that cone has to go to 0, 0. If it's not at 0, 0, then it's gonna be short and it's gonna look short. And like John said in his message, you are sometimes ending up with a cone that's devoid of sealer, which is not what you want. And this is great.
Well, I was interested in that the etching and waiting a minute. That was something I was unfamiliar with.
Oh, it's actually the rinsing for a minute. So
Yes.
you don't want to over etch the end, but you really want to rinse it out.
All right. Well, thank you again, both of you, for stepping in. It was wonderful. It will go out on our website. It takes a few weeks, but this is going to be a good one for all of us to rewatch again.
Great.
to come up again with our upcoming events. Our next webinar is going to be Wednesday, May 20th, and it is with Naja Usman. She sits on the AAE committee, and we're going to have a fireside chat. The endodontist as the quarterback. What is the value of early endodontic partnership in supporting oral and systemic health? This is in Save Your Tooth Month, so we decided to do something really interesting with the AAE. She sits on the Public Affairs Committee, really interesting background. So that should be a fun, different course for all of us again, so please look out for that. Our next hands-on opportunity, again, is in Nashville, Tennessee, Saturday, June 6th, and that is with two of our top people. So you will get hands-on experience from people that have done thousands and thousands of Gentlewave cases. So please come to that, and you can take a picture of the QR code here if you would like to sign up. That one will get sold out. Lastly, some of you all know, hopefully, we have launched our Flow Logic files. We're getting really good feedback on those. When you complete your survey from the course today, there will be an area for you to sign up for a sample for those. So please sign up for a sample. Give us your feedback with them. We look forward to hearing more about that. Otherwise, we are ending right on time, the perfect lecture, not going late. So thank you, everybody, for your night. Go enjoy it and have a nice week.